Hi class, due to the length of the digestive system disorder chapter, I'm going to leave the review of the digestive system to you, so we're going to go ahead and just jump down into the common manifestations of the digestive system disorders. So some of the most common manifestations include anorexia, nausea, vomiting, and bulimia. These are signs of some kind of digestive disorder or condition somewhere else in the body that can cause this. These symptoms include systemic infection, uremia, which is too much uric acid in the blood, emotional responses, motion sickness, pressure in the brain, overindulgence in food and drugs, and pain can cause these things. So these are just some general signs of disorders. And it doesn't always have to be a digestive disorder. It can be other things like systemic infection. So anorexia and vomiting can cause severe complications, including things like dehydration because you're not getting enough fluid, acidosis, and malnutrition. So acidosis is where the blood becomes acidic. And also malnutrition for long-term anorexia. Typically anorexia, which is not having an appetite, often precedes the nausea and vomiting associated with digestive disorders. And then nausea is that unpleasant subjective feeling, meaning it's subjective to you, to the person. They have to tell you they're nauseous. And it can be stimulated by various things such as distension, irritation, and inflammation of the digestive tract. It also can be associated with smells, even visual images and pains, and chemical toxin and drugs can cause nausea. Nausea and anorexia and vomiting are all really strong protective mechanisms. If we eat something that makes us sick, we don't do it again, or we see something that historically was around inedible food, such as feces or something like that. We don't want to eat beside where there's feces, so it makes a very strong reflex. Vomiting or emesis is a reflex. There's a vomiting center in the medulla oblongata, and it coordinates the vomiting process and helps protect the trachea and the airway during vomiting. And it involves the forceful expulsion of the chyme from the stomach, and it can also cause the reverse peristalsis of the bile from the intestines into the stomach. So that's vomiting. Bulimia is actual eating disorder where a large amount of food is ate, and then a recurrent vomiting occurs. And this recurrent vomiting after eating can damage the oral mucosa, which is the mucous membrane in the mouth, and also the acidity can damage the teeth and even the esophagus. So the vomiting activation center usually initiates from irritation or distension of the digestive tract, and various secondary factors such as smells and sights can go to the brain too, and even ischemia, if you remember, intracranial pressure increases, can cause projectile vomiting. Pain and stress can activate it. Motion sickness, increased, we already talked about that. Stimulation of the chemoreceptor trigger zone. So certain drugs and toxins and chemicals can induce vomiting. So a couple things that happen is the center is stimulated, and then it coordinates it through several of the cranial nerves. And those cranial nerves are going to do things like close off the glottis. The epiglottis is going to close off the glottis so that the emesis does not go down the trachea. You're going to see things like hypersalivation and pallor, sweat and tachycardia. So the blood is flowing, your heart rate goes up. The glottis closed. You're going to have deep inspirations because you're going to use that pressure from the respiratory the inspirations, and you're going to use that pressure from the abdominal muscles to push down on the stomach, and it's going to forcefully contract, and we're going to open up the gastroesophageal sphincter, and the fundus of the stomach is going to relax, and food is going to pass through peristaltic waves, and it's going to pass up through the esophagus, out the oral cavity, and it can go up into the nasal cavity. That pressure forces the chyme out of the mouth. So, and we can also get some stuff out of the small intestines here. So that's the vomiting reflex. So just to kind of recap, we don't have deep inspirations. We're going to close the glottis off, raising the soft palate. Try to cover up the nasal cavity. We're going to cease respiration and stop breathing. This is going to minimize aspiration of the vomitus into the lungs. We're going to relax the cardiac sphincter, or gastroesophageal sphincter, force the abdominal muscles to contract, and it pushes the gastric contents upwards, and along with the reverse peristaltic waves. Some characteristics of vomitus include things we look for, things like blood, to see if there's hematoemesis. If it's coffee ground, that means that it has been acted on by the hydrochloric acid in the stomach. So that it looks like coffee grounds. It means the blood is being digested in the stomach. If it's red, it's hemorrhagic, and it may mean there's a tear or rip in the esophagus, and it hasn't been digested by the stomach. It's red. If it's yellow or green, it means it's from the bile in the duodenum. It's being also done. A deeper brown color may indicate that it's content from the lower intestines, so even farther down. Recurrent vomiting of undigested food may mean that there is some kind of problem with the gastric emptying. There may be obstruction or infection. That's vomiting. Diarrhea is the excessive frequency of stools, usually loose or watery consistency. It can be acute or chronic. It's frequently associated with nausea and vomiting when there's an infection or inflammation. Diarrhea can also be accompanied by a cramping pain, and prolonged diarrhea can lead to dehydration, electrolyte imbalance, acidosis, and malnutrition. We see in certain other countries there's certain diseases that cause excessive diarrhea, and a lot of these people end up dying just because they could not maintain hydration and the correct electrolyte imbalance. If they were able to have Gatorade, they would survive this chronic diarrhea. Things like cholera in other third world countries, they would survive and wouldn't die from diarrhea. Some common types of diarrhea include a large volume diarrhea. It indicates usually secretory or osmotic issues because the watery stool results from increased secretions into the intestines. So the increased secretions pull the water along, and then we are unable to reabsorb that water, and it's often related to infection. So we're unable, like I said, to reabsorb the water. Small volume diarrhea is often caused by inflammatory bowel disease. The stool may contain blood, mucus, or pus, and it's inflammatory bowel disease, and it's accompanied by abdominal cramps and tenesmus, which is the feeling of not being able to completely empty the colon. Diarrhea is fatty diarrhea. The frequent, bulky, greasy, loose stools. It has a foul odor. It's characteristic of certain malabsorption syndromes like celiac disease and cystic fibrosis. So they're unable to absorb the fats, and then it goes out through the digestive tract. The fat usually is the first dietary component affected, but the presence will interfere with the digestive of other nutrients. Often the stomach, the abdomen is distended. Blood and stool may occur in normal stools with diarrhea, constipation, tumors, or even inflammatory conditions. There's a few ways to describe the blood. One is frank blood. That means it's red, and you can see it usually comes from lesions that are near the exit point, so in the rectum or the anal canal. So something maybe like with hemorrhoids. Occult blood is where you cannot visually see the blood in the stool, but it can be detected through a stool test, from small bleeding ulcers primarily. And then a melena is where the dark colored tarry stool, and it usually indicates that there is some bleeding in the upper digestive tract, and then the bacterial action kind of colors the stool. Gas comes from a few different places. One is swallowed air such as drinking from a straw or carbonated drinks. The bacteria can produce gas when they digest the food. Certain foods or alterations can alterate in motility. Excessive gas causes irritation, which is belching. Borborigumoses. Borborigmus, rumbling, abdominal distension and pain, and flatulence, which is passing gas. Constipation occurs is when there's less frequent bowel movements than normal. Usually the stools are hard and small. It can be acute or chronic again. It may be caused by decreased peristalsis, where it allows more of the fluid to be reabsorbed, so that it has less fluid and causes it to be harder. Periods of constipation can alter with periods of diarrhea. Chronic constipation can cause hemorrhoids, anal fissures, and diverticulitis. Some of the causes of constipation include a weakness in the smooth muscle because of age, in the elderly or weakness, inadequate dietary fiber, inadequate fluid intake, which is can lead to dehydration, failure to respond to the defecation reflex in a timely manner, and so it slows the tract down. Immobility, neurological disorders, drugs, particularly opiates, some antacids and iron medications, and then also obstructions by tumors and strictures. Strictures are where we have maybe some scar tissue building up in the digestive tract. Fluid and electrolyte balances, we did a whole chapter on that. Common ones that are associated with digestive tracts include dehydration and hypovolemia, which is the low volume of blood. Electrolytes can be lost during vomiting and diarrhea, and we can end up with some acid-base imbalances like metabolic alkalosis, which results from excessive vomiting, which we're losing the acid, or we can have very severe vomiting and cause metabolic acidosis because of the loss of bicarbonate of the duodenal secretions. So we lose the bicarbonate and we go into an acidic environment. Diarrhea can also cause a loss of bicarbonate, which is a buffering system for our blood. The pain in the digestive tract is often a visceral pain, which can manifest as a burning sensation, which often indicates inflammation and ulceration in the upper digestive tract. Dull aching pain, which is typical of stretching the liver capsule. Cramping or diffuse pain can indicate inflammation, distension, and stretching of the intestines. Or colically, or like a severe sharp pain, can be recurrent with smooth muscle spasms and contraction. And it can be from like severe inflammation or even obstruction. Somatic pain can also deal with the digestive tract, The somatic pain receptors directly linked to the spinal nerves, and may cause reflex spasms of the overlying abdominal muscles. They're usually steady, intense, and often well localized, so they're very specific where they are. And it can involve inflammation of the parietal peritoneum, which is the peritoneal membrane, and often exhibit rebound tenderness. So it can identify by pressing down on the on areas of the abdomen. When we release, is their pain exhibits there, and that lets you know it's localized inflammation. Referred pain is a common phenomenon, and this is where the pain is perceived at a different site of origin, and it revolts when these visceral and somatic nerves converge at one spinal cord level. So they converge together on one spinal cord level, and the pain kind of gets mixed up. So the visceral pain is perceived as the somatic pain, which is at one location, and the visceral pain is at another location, and you think it's at somatic. This can assist diagnosis or delay depending on the problem. Some referred pain is very well known. So you can see on this chart here some referred pain with the left side of the heart. So if the pain in the heart, it translates to the shoulder and the arm. You can see that, small intestine pain right here in the middle, the cholecystitis, gallbladders here, biliary colics here. Some ulcers are here, gallbladder. So they're referred to different areas. I don't see the appendicitis right here. Very specific. It's a localized pain right here. So referred pain can kind of indicate a little bit, but you can see they're spread out all over the place to a certain degree. Another common manifestation is malnutrition, and it can be limited to like one specific nutrient. Maybe you're iron deficiency, or it can be general malnutrition. The causes of limited malnutrition are specific to whatever we're missing. So if it's a vitamin D B12 deficiency, it's going to cause things like pernicious anemia, or iron deficiency can cause iron deficiency anemia. General malnutrition can come from chronic anorexia, vomiting, and diarrhea. And also other problems such as chronic inflammatory bowel disorders, cancer treatments, wasting syndrome, and lack of available nutrients from the environment. So we're unable to purchase food for a person. Some basic diagnostic tests include radiography, X-ray, often used with a contrast medium that is ingested, and it allows you to see how things are moving along the track. Ultrasound can show unusual masses. CTs, computed tomography, can show some of the internal organs. MRIs can give the most details. The CTs and MRIs can use radioactive tracers and can look and see how things are actually metabolized by the liver and the pancreas. Fiber optic endoscopy is where you're going to use a camera that's going to look up through in the upper GI tract. A biopsy can take a sample during these procedures. A sigmoidoscopy and a colonoscopy. They both can look in. They're going to look up to the colon and go farther up, and they can biopsy and remove polyps at the same time. We can analyze the stool specimens, looking for signs of infection, bleeding, or parasites, and malabsorption. We can do blood tests that can indicate liver function, pancreatic function, and even look for cancer markers. Common therapies and prevention. Dietary modifications. So if there's celiac disease, you can go on a gluten-free diet. Reduce alcohol and coffee intakes can reduce things like GERD, acid reflux. Increase fiber and fluid intake. Those are some dietary options. Stress reduction techniques can, because stress impairs the immune system, the stress reduction can help build up and allow tissue healing. There's various medications. Some drugs that are used in the digestive tract are things like antacids, which relieve pyrosis, the excessive acid in the stomach. Antiemetics that relieve vomiting. Laxatives or enemas, which treat acute constipation. Anti-diarrheas reduce peristalsis and relieve the cramps. Sulfasalazine is an anti-inflammatory, antibacterial that can treat IBS, inflammatory bowel disease. Clarithromycin and azithromycin can treat Helicobacter pylori infections, which actually is now what we know the cause of stomach ulcers. And this antibacterial, along with PPI, which is going to reduce the stomach acid, is going to allow the infection to be treated. Sulcrophite is a coating agent, and it can coat the stomach and help decrease the help enhance the mucous membrane barrier against irritants, such as NSAIDs. And NSAIDs kind of irritate the mucosa, and the sucralfate can kind of cover it and prevent the irritation. Anticholinergic drugs reduce the parasympathetic activity, which is resting and digesting, so that's going to reduce secretions and motility and slow it down. Histamine 2 antagonists are useful for gastric reflux, and protein pump inhibitors reduce gastric secretions. Alright, so here's a nice chart, and it kind of just goes through the different ones, and it tells you what action it takes inside the body. What I want to do is kind of stop here. This is a long section. If you want to read over the PowerPoint, the whole PowerPoint's posted, or you can read through your textbook, and you can go through the quizzes using it. But I'm not going to go and bore you to death with every single slide. All right, so all right, good luck.